Next on primary care, prostate health. Some facts may be hard to hear, but they're impossible to ignore.
These are numbers I think that are very important for African American health. At least know what your PSA.
Right.
If you don't know it, have your wife or girlfriend know what the PSA is.
Hello and welcome to Primary Care, the show dedicated to improving the health of African Americans. I'm your host, Dr. Lonnie Joe. If you're a man over 40, there's a good chance your prostate is already changing. But do you know what those changes mean for your health? From enlargement to inflammation, even cancer. Prostate conditions affect millions of men, often without symptoms in early stages. And for black men, the risk is even greater. Prostate cancer is 70% more common for them than other groups. Today on Primary Care, we're discussing what every man and woman who loves them need to know about prostate health. Here to help us understand that is Dr. Ray Littleton. Dr. Littleton is a senior urologist at Henry Ford Health and clinical assistant professor of Wayne State University School of Medicine. He has a deep commitment to black men's health and with years of experience in helping patients navigate clinical health concerns, and a lifelong friend. Dr. Littleton, welcome to the show.
Thank you.
Good.
Pleased to be here.
Ray, why is it important for us to have this discussion today, a conversation about prostate health?
Well, I think it's very important because a lot of African American men don't really know what's going on in their bodies. These changes do occur when we start getting around 40 years of age and older. In fact, you mentioned that prostate cancer is very high among African American men. About 1 in 6 men probably will develop prostate cancer at one point in their life. But you know, nowadays with the technology and the PSA levels, we can detect this often quite early. And this can be beneficial and add to the longevity. The one thing about prostate cancer, a number of cancers that do occur in men, you know, ranging from lung to GI. However, prostate cancer represents 37% of all known cancers that do occur in men. So it's important for them to know.
37%.
Yes.
So what is the prostate?
Well, the prostate is a male sexual organ, and do you mind if I use this prompt?
Sure, go right
ahead.
ahead.
Okay. It is a gland that sits just below the bladder, and again, it's a sexual organ that produces the fluid for which the semen is emitted. The seminal vesicles sit right behind the prostate, and during sexual intercourse, they will push out their fluid, which will contain the semen and spermatozoa. Of course, the sperm are created in the testes, but they travel up through the vas deferens and are stored until sexual intercourse does occur.
So men get enlargement of this gland, the prostate, okay? We call it hyperplasia or BPH. Tell us about that.
BPH usually is going to start occurring in many men around the age of 40, as you mentioned earlier. It typically is a symptom complex, and it's composed primarily of decreased urinary flow, difficulty emptying the bladder. A lot of men will complain about nocturia, which is getting up at nighttime to go and urinate. Some of them will have it only once or twice a night, but many times it's going to go 3-4 times a night, and that's a lot more than usual. There are a number of other symptoms of BPH as well, like urinary tract infections, the decreased flow I think I mentioned earlier, urinary frequency, and of course the nocturia. Urgency is when the symptoms become more severe, and some of the men will tell me that they have to know where every bathroom is. In fact, some of them will carry a small bottle in the car because they're afraid to stop and have to go urinate.
Right. We'll go into a new building, have to know where the bathroom is, which floor, which stairwell.
Absolutely.
So is BPH basically diagnosed on symptoms alone?
No, well, we also do a physical exam when men come in complaining of those that symptom complex. And generally that involves doing a digital rectal exam as well.
Which men still are afraid of to some degree.
Very much so. And a lot of men won't allow you to do it. Sometimes what we'll do is a prostate ultrasound, and occasionally I'll do a bladder ultrasound, because you can sometimes see through the bladder an image of the prostate. Yeah. The other thing I use ultrasound for is to look at the post-void residual, because again, that's another symptom. If you're not able to empty your bladder completely, sometimes after urination there will be a large volume.
So you go to the bathroom, next thing you know, you gotta go back again.
Correct.
Right.
The double voiding is also a very common symptom of
I've even
BPH.
had wives tell me, "Oh, he's gonna go twice."
Yeah.
So
very true. Yeah. Guys will say, in 20 minutes I gotta go again.
Right. So what is the treatment for BPH?
The treatments vary. The classical treatment is a resection, prostate surgery, called the TURP, which we still call the gold standard. But there are a number of other less invasive procedures that are on the market now. There's medical therapy. There's a watch and wait therapy, because sometimes you'll get better on your own. Some symptoms will get worse one day and they'll get better, and a lot of guys will tell me they think they've gotten better with the supplements they get at the store, but they're probably just getting better because that's the natural history. But when the symptoms continue to get worse, usually they're going to need some sort of intervention from the doctor. There are some drug medications that can shrink the prostate. There are drugs that will also open up the urethra so that you can get a better flow.
How can primary care providers distinguish between BPH, or benign prostatic hypertrophy, and prostatitis?
Prostatitis is usually very uncomfortable. Those men will often have low back pain associated with their voiding symptoms. They may have suprapubic pain or discomfort over the area of the bladder. They may even have some dysuria, another symptom of BPH.
Is there more incidence of infection in prostatitis?
Yeah, well, there's two ways you can look at that. Two types of prostatitis. There's the non-bacterial prostatitis, for which we will do a urinalysis and we won't necessarily find anything. And then, of course, there's a bacterial prostatitis. The bacterial prostatitis is often associated with a bacterial infection, and that will respond to antibiotics. The non-bacterial prostatitis is a lot more difficult to treat.
More chronic.
It's more chronic, and sometimes we'll use antibiotics anyway, but we will also use some anti-inflammatory agents. And you can also send them occasionally for physical therapy. Over the years, there have been a lot of men that would come in for a prostatic massage, and they would say that would help them as well.
So, BPH, prostatitis, are they necessarily linked to other men's health issues such as erectile dysfunction or infertility?
Well, yeah, they can be, yes. It is very difficult if you've got pain in the area of the prostate or in the pelvis to develop an erection. So it can lead to erectile dysfunction. So that's actually fairly common.
Men come in all the time and say, any exercises I can do, any natural component, any vitamins that I can take to help improve my prostate health or even treat my BPH or prostatitis. Are we able to recommend anything that has some significant benefits over time?
There are a lot of things that are in the health food stores. Those that have saw palmetto might be a little bit more effective. Those that have beta-stilbestrol, elements in it. So you got to look at the ingredients, because a lot of them are just simple vitamins and zinc compounds, which don't often necessarily work. And I find that they will still come in to see us, and then we'll give them an actual prescription drug. I think that I try not to discourage men who want to try it on their own. I'll let them try it. If it works to them, great. If it doesn't, then I can give them a prescription for it.
At least they're aware of their symptoms.
Correct.
Paying attention, asking questions, seeking help. I think it's, sometimes, things like pain are a good thing for us to have, because it makes us pay attention to what's going on.
It makes you come in.
In this instance, in an environment where we have difficulty getting men in for services, healthcare services, you would think that something like this would drive them a little bit sooner. But I find that the average black male will ignore these symptoms and put them off or make adjustments in their lifestyle to accommodate prostate type symptoms, as opposed to actually stepping up saying, hey, I need an evaluation or I need to see the doctor.
Yeah, I think that's actually correct. They tend to adopt to the symptoms. And what they'll find is that if they're getting up more frequently at night, sometimes they will make adjustments where they're drinking less fluids, so they can get a little bit more sleep at night. But once they start beginning to lose sleep and they're tired in the morning, can't go back to work, et cetera, then they often will come in and seek some service.
Okay. Why is prostate cancer so prevalent, or more prevalent, in black men at the higher rates?
It could be related to genetics. It could be related to environment.
Family history, maybe?
Family history is extremely important. I've got patients where 4 out of 5 males will have prostate cancer. In fact, that is one of the risk factors. If there is a first-degree family member, either a father or brother, your chances of developing prostate cancer increase by 2. So it does go up. So it doubles. And it's important, very important, to take a family history for prostate cancer. I got a question for you. I want to show you a couple of pictures, since we're changed the subject. These gentlemen, what do they have in common? Let's see, we had Giuliani, Mandela, Dexter King, Harry Belafonte, Robert De Niro, and Lloyd Austin. Prostate cancer. Exactly. And as a result, a lot of people are not aware until high-profile people like that step up and say, I've had this problem, we're getting it treated. What people need to know is that it is a treatable disease. Now, you can even look at it as a chronic disease in many cases. So there have been a lot of new developments over the years. I'd like to mention getting a PSA. People are always asking, when should I start getting PSA? The American Cancer Society recommends getting it around the age of 50, 55, but we talked about family history. If you have a family history or a first-degree relative with prostate cancer, or if you're in a high-risk group, like African Americans, you need to start getting it a little bit earlier, say maybe at 45.
Right.
At least start talking about it around the age of 40, so that you will expect it by the time
This interfamily communication is so important across the spectrum. It's very important in prostate cancer. We see the same thing. I'm just amazed at how many people didn't know that Aunt Susie had breast cancer, or didn't know that grandma had colon cancer. I mean, a lot of first-degree relatives out there that have suffered and in some instances died from these diseases, and it's not very clear what they had. You ask patients about their family history, and they'll say, oh, I'm not sure, it was some kind of cancer. That's kind of a discussion that needs to be put to the forefront so that we can move those age groups up.
Absolutely.
I'm a victim of that experience, also having to have testing moved up because of family history. Also genetic testing involved with it also. But here again, if we don't have that discussion, we're going to miss a lot of patients out here. So you're right. Knowing that family history, knowing that background gives us an opportunity to say, well, instead of waiting till 50 for this test, maybe we need to do you at 40 or 45.
Correct. That's extremely important, and that's what we'd like to emphasize. One of the things I used to do earlier in my practice is that I would work with groups like Alpha Phi Alpha and Sigma Phi Beta and 100 Black Men.
Right.
The 100 Black Men will do have us do yearly prostate screenings. And almost every year we find at least one person that has a high PSA, and then I can go ahead and recommend that
Ray,
they go on.
Do you remember the year we had the NMA here in Detroit?
Yes.
15 or so, and we
did
prostate screening?
Correct.
How many people did we find, just screening did we find? I think it was 4 or 5 or 6.
Correct.
Something like that in that range that would not have been found if the screening hadn't taken place.
Exactly.
So we're talking about early diagnosis in a disease state that is very, very important, and in a lot of instances, it's asymptomatic. I mean, what are the symptoms of prostate cancer?
Good question. The symptoms of prostate cancer, really, there can be no symptoms sometimes.
At all.
Absolutely none. And sometimes later on, as the prostate grows, you'll have some of the same symptoms that sound like BPH, or benign prostate hyperplasia, that we talked about earlier. But occasionally there's hematuria, urinary tract infection, difficulty voiding, urinary retention. If a guy's got retention, I'm automatically thinking he needs a PSA, let's do a prostate exam. And the thing that bugs me about a lot of the black guys that come in, they know all the baseball scores. They know all the everybody's averages, but they don't know what a PSA is.
Yes, right.
They don't know the blood pressure or the PSA.
Right.
They need to. These are numbers I think that are very important for African American health. At least know what your PSA.
Right.
If you don't know it, have your wife or girlfriend know what the PSA is.
No,
you know?
that's exactly. Know your numbers.
Know your numbers.
Like your bank
If I don't
account,
get anything else across, know your numbers.
You know how much left on your credit card that you can charge. You need to know what your PSA is.
Right.
So, but here again, we just finished the discussion on prostatitis and BPH. Are these gateway symptomatologies to prostate cancer in any form?
Well, the symptoms overlap each of those diseases, but if you develop prostatitis, that does not necessarily mean that you're going to develop prostate. They're two completely independent. And some people who've had prostatitis for years never get prostate cancer. On the other hand, they do overlap. And so you can have anything that causes obstructive symptoms can cause prostatitis. And obstructive symptoms make me want to rule out a prostate cancer. An elevated PSA usually, it should be under 4, but when it starts to reach 4, actually I tell the patients 3.9, because once it reaches 4, I'm starting to think about doing a biopsy. And the other thing is I'd like to follow the patients over the years. When you're younger and 40, it might be less than 2.5. But again, let me see you again in 2 or 3 years and repeat it, because I'm watching the rise in the prostate PSA as well. And if that does occur, I've become a little bit more suspicious.
Okay. So since the focus is on this increased incidence of prostate cancer in black men, should we be screening them differently? Should we start earlier in age? Should we look at the PSA differently? Should we be pushing and cajoling to some degree that the prostate exam is a necessary part of the evaluation for them?
Well, you're talking to a guy who was trained before PSA. We did digital rectal exams on everybody. So I think that we should still do that. Although, some of the younger doctors simply do only a PSA. You can get away with that, I think, but if a person has symptoms, a decrease in, urinary flow, the hematuria, urinary infections, or any of those, especially nocturia, because one of the things I found out about nocturia is that your insurances won't pay for a screening PSA unless they have symptoms. So I ask everybody if they've got nocturia. Automatically, it's covered.
Yeah,
they can get that covered. So if I think I want to do a screening, if they've got symptoms, they're going to need a PSA test, and then we go from there.
Yeah, nocturia is not hard to diagnose. especially over the age of 40.
I know.
Good. So basically, tell us about the PSA test. It's a blood test. It's very simple, nothing to be afraid of course. But in black men, is there an association with the doubling time, even if it remains below that 4.0 level?
Yeah, doubling time is very important.
I've seen some patients who've gone from 1 to 2.5, and we say, oh boy, and if we question closely and we draw out those symptoms, we have found some cancers below 4.0.
Yes, don't get me wrong. You don't have to have a level over 4 to have prostate cancer. Mm-hmm. I found a number of people with normal PSA levels who do have prostate nodules and were later found to have prostate cancer. Mm-hmm. So we went ahead and treated them.
So where is the role of further diagnostic testing, or what is the role of further diagnostic testing? In particularly, you mentioned earlier ultrasound. A prostate ultrasound seems to be invaluable in assessing these patients.
I think that's a good test. It really tells me about the size of the prostate gland. I can also, again, get the post-void residual studies as well. I think there are some other studies that we use also. For example, the MRI of the prostate is becoming a really good exam.
As a screening tool?
Well, I wouldn't use it as a screening tool necessarily. I typically won't get that unless the PSA is already elevated, or I have some other reason to get that study. A biopsy is the ultimate thing that's going to tell me if a person has prostate cancer.
The gold standard.
Yeah, that's the gold standard. The MRI or the ultrasound alone is not going to make the diagnosis. They will suggest an abnormality, and that is what leads me to proceed with a biopsy.
Mm-hmm. So basically, how do we get more men in line to start talking about this disease? It starts with a conversation. How do we get them into the light of being educated about prostate cancer and get them in for some screening? Because I think that is the way that we're going to change the disparity that we see in the diagnosis of prostate cancer. What can we do as primary care physicians with these patients to level this playing field?
Well, again, I think that when the guys are coming into the office, you do need to at least ask them about their prostate health. Mm-hmm. All the symptoms that we talked about can be mentioned. You definitely got to talk about the family history of prostate cancer, or any prostate disease for that matter, because then that may lead you on to the next step of having someone get a screening PSA.
So how often should the average male above the age of 40 see their doctor or be involved in a routine screening examination for prostate cancer?
That's a good question. When PSA first came out, we found so many prostate cancers that we initially recommended, the AUA initially recommended annual PSA levels. The United States Task Force looked at that, and they thought too many were being done, and they recommended that it not be done. And the recommendation ultimately was every 2 to 4 years. This we felt a little bit uncomfortable with, especially for African American men with a higher rate of prostate cancer and death due to prostate cancer. We felt that we should probably, so they backed off on their recommendations and are allowing you to annually have that discussion, and then it's up to the patient to do the blood test, which, as you know, is pretty simple. They're getting blood tests anyway for other diseases, and it's just one additional test.
Okay. So how can we sort this out a little bit? Because there are different forms of prostate cancer. I've seen very aggressive forms of prostate cancer that metastasize at an alarming rate from the time of diagnosis, having all of the components and the necessary types of treatment and diagnostic approaches. If we don't know the cell type that we're dealing with, it becomes difficult to say how you should really schedule this.
Well, Yeah, what we like to do is once you do the biopsy, you want to look at the Gleason grading. And
that's a way of rating the
yes, that's a way of
aggressiveness
rating the aggressiveness of the cancer on that particular biopsy. And we grade that area 1 to 5, and we look at 2 different areas, add them together, so you can get a number anywhere from 2 to 10. Typically, gradings that are 5 and below are almost benign, so we often don't even treat that. Even a Gleason 6, 3 plus 3, is now being looked at as a less aggressive, we call it low risk, particularly if the PSA is under 10. We look at that as a low risk. And some of those men can have the prostate cancer all their lives. You can talk to patients who've had relatives in their 70s, 80s, and 90s who have had this disease, and they're still living with it and never treat it.
Right.
And I try to reassure them that if you've got this, let us follow you along. We can get PSAs every 3-6 months, and then we can also, if we see it increasing, at a rate over 15% per year, then I'm going to probably recommend another biopsy, and I'll probably do a MRI study. And I'll alternate the MRIs, because with the MRIs, the radiologist will be looking at areas that they call PIRADs, and if it's a PIRADS 4 or 5, that's usually associated with a higher risk and higher grade prostate cancer. That's the person I'm going to be doing another biopsy on. So if you were low risk before, and say a year or 2 from now, PSA goes up and your PIRADS goes up, you're getting another biopsy, so that we can start talking about initiating therapy.
Lastly, we all have some significant others of one form or another in our lives, and I find that it's a reoccurring theme that the wives are always complaining about their husband, and it comes back to haunt you that here's another prostate complaint that the wife is bringing in the office about her husband. There is a role there.
Yeah, I agree, and you're right. And sometimes it's a good idea to bring your spouse in with you, because I'll tell you, sometimes they'll tell you things that your husbands won't even mention. So, seeing them as a couple, I think is a very good thing.
Right. Ray, this has been outstanding. Thank you so much for joining us
Oh,
on the
it's
show
been
today.
a pleasure.
We'll have to do it again soon.
Yes,
okay?
Indeed.
Good. Our guest has been Dr. Ray Littleton, urologist specialist at the Henry Ford Health System and clinical assistant professor at Wayne State University School of Medicine. When it comes to prostate health, silence is not an option. It is important to speak up. See your doctor. Be proactive. There is no reason that any man, and particularly black men in this country, should die from prostate cancer. Take control of your health. For Primary Care, I'm Dr. Lonnie Joe.